Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Welcome, everyone, to another episode of The Pursuit of Health. I'm your host, Rainer Schur, and joining me back on the show today is Jared Rhodes and Colleen Smith. Welcome back.
Thank you.
Thanks for having me.
Section 001 of the Affordable Care Act prohibits new physician-owned hospitals from receiving Medicare dollars. Now, that raises an important question. Where did this prohibition come from, and should it be repealed? And that is not simply a theoretical question. Currently, the Centers for Medicaid and Medicare Services is requesting public comment on whether or not to relax physician-owned hospitals from participating in federal programs. And even amongst those who claim to be for free markets in healthcare, there seems to be disagreement about whether or not repealing this prohibition is pro or anti-free market. And so that's what we're going to get into today. And a natural place to start would be to simply ask, where did this prohibition come from? And why are physicians in particular singled out as owners of hospitals?
This prohibition came about, like you said, this version of it, with the Affordable Care Act, and it came about because physicians were thought of as being in a position to kind of uniquely benefit from their own referral decisions. And the idea is that, look, if you're you're a physician, you see people on a daily basis. That's your like your intake of patients, right? And you're constantly referring them out to what maybe need this test or that procedure, et cetera. There's lots of things that you can then direct in terms of their care, and there is a belief, and I mean, it's not in some sense it's not unreasonable, but there's this belief that if the physician can then also benefit from the downstream service that they are recommending and referring the patient to, well, isn't that going to possibly drive a lot of utilization? Could that drive overutilization? Might they just start referring patients to get these things because maybe because they just there's going to be a financial benefit there, and so there's this idea that, well, maybe there's a conflict between the having a financial interest in some facility that's performing these services and the kind of judgment that you have to do as a physician as to what you're going to recommend, right? So that sort of led to what we think of as like the Stark laws, and then there are exceptions to that, and I don't know, we probably don't need to go into like all the history of it, but there was when they initiated some of these laws, they grandfather in certain organizations and hospitals. And so if you have a hospital that was already physician owned for many years leading up until that, well, that was grandfathered in, and that's sort of a feature of the law. The thinking there is like, well, you don't want to, somebody who's already established, you don't want to, suddenly abolish their, make illegal their business model. But maybe from this point going on, we should stop it. And so that was sort of the thought and the justification. Overall, it tends to be a sort of a cost and expenditure related justification, and I guess to a certain extent also like like a quality of care kind of concern too. Those are some of the things that went into this.
I think we should also just say, like, the laws didn't prohibit these like physician-owned hospitals entirely. They just prohibited them from participating in Medicare and Medicaid. So they're unable to get money from the government for the care that they provide.
Yeah, that's kind of the key here too, because Medicare being such a large and kind of dominant payer, I think it's something like 94 to 96% of seniors. So it's a large portion of a part of the market. I guess it's not the whole market. You need to recognize that. But if you're talking about older adults, it's a massive chunk that is now kind of carved out of this ability to have this a physician-owned hospital where you are referring patients there, and they would be able, if they're on Medicare, that's not an allowed payer now for that situation.
Right, and that also seems to kind of frame the way that some people are thinking about this prohibition, that it's not anti-free market, right? Because we're talking about a government program here. Like it's not an actual prohibition on physicians starting up their own hospitals. They just can't do it on the taxpayer's dime. And on top of that, some people think like, well, yeah, physicians are kind of like uniquely primed to game the system because of things like self-referral, um, because particular physicians orthopedic surgeons can set up like boutique hospitals where they just focus on hip and knee replacements, which bill very well, and so like that's leaving less money on the table for hospitals that take all comers, right? And so from that perspective, it actually looks like a little bit more plausible that like it's not as straightforward, right?
I think it a little bit depends on what the argument is, but if the argument is that if you allow physicians to take these taxpayer dollars from Medicare and Medicaid, then that means that there's going to be more government expenditure. And so more money is coming out and is going to more people because it's going to more people. And then also on top of that, there's this claim that physicians are more likely to refer patients for more tests and more services and more specialty care if they're referring within their network and stand to gain a little bit from that. And so that's going to mean that the government expenditure, the Medicare and Medicaid expenditure goes up and is more. So, I think you could say, all right, yeah, that is more government money, and more money coming from the government and therefore more money coming from taxpayers. But I would say that there are a couple of things that you could push back on. One is the question of whether or not it is actually the case. Do we have actual data showing that physician-owned hospitals do this more than corporate or nonprofit hospitals? Because the corporate and nonprofit hospitals where I get my care and where I work, we tend to refer within the system. And I have a big incentive to stay within that system because there's this sort of continuity of care and everyone can see everyone else's notes and everyone can see all the, radiology reports that I've had. And so I think this argument that kind of referring within the system and the biggest difference is the doctor salaried or are they making a little bit of money from this referral? And then, is that even wrong? Is there data that shows that one of those two situations leads to increase in utilization in a way that's inappropriate? I'm not sure that there is. So I think that's kind of one question. And the other question is, are we increasing the taxpayer dollar that's being put into healthcare by opening up the number of people who are able to receive taxpayer dollars? Or is that pool really actually staying the same? I mean, by allowing physician-owned hospitals to accept care money from Medicare and Medicaid, you're not increasing the number of Medicare and Medicaid patients that exist. You're just spreading out those dollars. They're going to more people. So, in fact, are we not actually improving choice for those patients? Maybe improving shoppability of healthcare. So, I think there are a couple of different things that you could look at.
It's very complicated and twisted, and I mean, I think it's a healthy and good thing to be thinking of it from as many angles as you can. The other thing to be thinking about in this, Colleen, you mentioned like taxpayers are involved, and there's a taxpayer interest here. There's it's it you know One piece of context to keep in mind is that there's a subsidy involved in Medicare. The Medicare program, if you're on Medicare, you do pay a premium, but that premium does not cover the entire program. Some of this is one of those issues where, some of it would potentially go away, I guess, or at least a component of it would go away if you could say, well, the premium that the Medicaid and Medicare enrollee is paying, completely covers it, and then there's no whiff of any subsidy involved, and so you can't say that physicians are like chasing some sort of like free money or something. But even there though, like it's not exactly the case that Medicare reimburses at some like lavish level either. And I think this is again not like some you know uh, like the only argument or something, but I think it's again part of the context, which is that Medicare, if anything, it's hard to know what the like market price is for anything because in healthcare we don't have market prices, but at least in the sort of hierarchy of Medicaid, Medicare, and private reimbursements, Medicare is in the middle between those three. Um, and and yes, there's a subsidy involved, but it's not like it's paying. It's not like it's that the Medicare is in that stack is inverted and like Medicare is on the top, and that's the one that to do any procedure on Medicare, you get paid an enormous amount, and so therefore, obviously physicians want to flock to it. I think more the reason that they want to be included in and to be able to see Medicare patients and to build that is because of the market share that we talked about. Like I thought the huge just a huge portion of it. Once you get rid of those 95% for that population, there aren't as many people around to be your customers in a sense, to look at it that way. So it's probably. I mean, I tend to think of it as not so much that they're chasing like free money that the government is like dropping out of helicopters wastefully. It's more that the government has done this thing of capturing this enormous group of patients. And okay, well, if you want to do anything for those patients, if those are your patients, you kind of need to be able to to take that reimbursement model. And so it's more of like a just a access to a set of customers is and which I mean you could think of that as like a subsidized activity, I guess, in a way, but it's so I think it's worth noting that it's not exactly the same as if Medicare were reimbursing at way above, like obviously way above market values.
And I think this would look very differently if, for example, these government programs only served a very small portion of the population. Let's say, I don't know, like 35-year-old destitute men, right? And then if you have physician-owned hospitals saying like, well, we can't survive if we can't serve this, well, yeah, then like I'd be like, okay, well, you're just subsidy seeking. But uh, Medicare represents like pretty much all senior patients. And on top of that, we do get most of our healthcare in the last few decades of life. So that's a huge part of the market. And as further kind of proof of this, like no new physician ho owned hospitals have really been created since the passage of this prohibition, right? So like the idea that, well, it's not a real prohibition. You can still go out there and build a physician-owned hospitals. Well, th they don't really exist.
In
Yeah.
fact, many have closed or sold their shares to corporate ownership.
Yeah, yeah. The number I think is something in the neighborhood of like 250 roughly nationwide, and that just kind of I've seen a graph of this, and it just sort of levels off right after the Affordable Care Act is passed, and this like I don't know what the right or most accurate word to call it is. Like I think I've called it a soft ban or a quiet ban before. You definitely want to be careful not to call it a literal ban because it's not, but it's close. It's in the neighborhood of that.
But this prohibition on physician-owned hospitals receiving Medicare dollars is definitely something that people are starting to revisit now. And I think part of that is the wider context for the Affordable Care Act, where people thought at the time that, oh, like if we have bigger healthcare systems, we can have more economies of scale, more efficiencies. And I think really like that kind of perspective has changed in the realization, like actually with these larger healthcare systems, there's less competition and prices have gone up. And so people have kind of thought like, well, yeah, maybe this prohibition should be repealed to get in a little bit more competition. And one way that people have been advocating for that is to challenge the supposed evidence that physician-owned hospitals are some kind of like unique threat to taxpayers as opposed to corporate-owned hospitals by pointing out that corporate-owned hospitals also engage in some of these behaviors, and the physician-owned hospitals are more competitive on price and whatnot. But while I think that that is an interesting question to ask, like who is actually a bigger threat to the taxpayer, for me, it doesn't necessarily follow that if you could prove that one group of owners is more of a threat than the other, that therefore justifies that an entire class of owners should just be banned from owning hospitals, right? Because there are going to be people within that group that are not like other people in that group. So why should they not be able to be involved in the healthcare system because their colleague, whether or not they're a physician or a corporation, is scamming the taxpayer? So even if we were to grant that either physician-owned hospitals or corporate-owned hospitals are like uniquely bad, I think what it actually points to is that there's incentives within the system that lead to that kind of behavior. And so that's probably what we should be going after.
Yeah, I
Yeah,
think we
and
should fit nonprofit hospitals in the same kind of bucket as corporate-owned hospitals as well. I know that they're sort of a little bit of a different, um, like a little bit of a different thing, but they're also, kind of they're allowed to accept money from Medicare and Medicaid. They kind of exist in this world. They're supposed to provide some charity care, but just like corporate owned hospitals also provide some charity care. And I think to your point, Ray, there's no, if you look at the whole spectrum of corporate owned and nonprofit owned hospitals, there are going to be some that are outliers that provide more charity care. There are going to be some that are outliers that are more likely to be driving up prices and doing sort of internal referrals and kind of behaving in ways that game the system. They're going to be, there's going to be a whole spectrum. And I think that would probably be the same for physician-owned hospitals.
yeah. Yeah, this is there's a part of this that is a little bit like the Medicaid fraud issue. Like if that's a problem, which it is, there are different ways of going about it, right? Different ways of sort of tracking down fraud after the fact or trying to prevent it. Those are sort of like two different strategies. One thing I don't hear a lot on this issue, and I'm not like proposing that this would be the one solution to it all or anything, but I'm surprised that we don't hear more people saying, well, okay, well, why don't we allow the ownership, but then we monitor it later, and we sort of like we do some utilization review and see, okay, does there seem to be a pattern of like crazy referral for things that don't make sense? Okay, well, if that's the case, then that gets to your point, right, where you're saying like, okay, well, maybe we just punish the bad actors, not everybody. Like not just assume every physician is going to be, practicing in a way that's way out of whack with standards, right? Because they're trying to line their pockets, right? So instead of treating everybody that way, why don't we just, if we think there is an overutilization problem, let's measure it and follow up with where we see it. I mean that could be one way out of this. The one other thing about sort of Medicare is that it has less, almost no like prior authorization too, right? Like that's part of this. The I guess if you were listing the good things and the bad things about being a physician that who can reimburse and bill Medicare, one of the better things is that you don't have to deal with the prior authorization that private insurers all often have. The incessant calls and the checking up and requesting permission to do everything beforehand. A lot of times in Medicare, there's an ethos of let it happen first, and maybe only in the most extreme cases do they follow up. So it's sort of so that there's a benefit to as well, but it makes it worth asking. Well, is that has it been too lax? I mean, maybe that's the thing that could tweak this slightly in one way to make it a better outcome.
I mean, so one question is, well, are corporations or physicians more of a threat to the taxpayer? And someone might even potentially grant that, yeah, okay, that's a clumsy kind of category, right? Like they might accept that not all physician-owned hospitals are going to be engaged in this kind of behavior, but then they might still think like, well, if we just repeal it now, sure, those that won't engage in that behavior will be free to compete fairly, but those that do engage in that behavior are still a threat to the taxpayer. So someone might completely grant what we're saying so far, that it doesn't make sense to discriminate between corporations and physician owners as such, but then say like, well, it's a clumsy ban, but it's a ban that serves a purpose because it's keeping back at least some of the bad actors, and so we should keep it in place because we don't want public expenditure to go up even further. What do we think about that as a standard by which to judge these kinds of reforms?
I think increasing prices in general results in public expenditure going up even further. So, what I would want is something that increases competition, which we know drives down prices. So I would worry that as long as you're kind of protecting the corporate and nonprofit hospital groups at the expense of the physician hospital groups, you're limiting competition, you're limiting the choices that patients have in terms of like where to go. And I mean, maybe the data doesn't completely matter, but there have been some studies just looking at hospital markets that are more consolidated or less consolidated, not in particular looking at physician owned hospitals or not, but just more consolidated markets. And it seems like those are more expensive. And I think that is a factor of the lack of choice for patients. If you have nowhere to shop, nowhere else to decide to put your money, then like what do? You just pay the price and you go to the one place that's available to you. So essentially this argument that if we add more people to the system that gets the money from the government, then the outcome is the government is just spending more money. I think that's kind of not the right way to think about it. I think adding more people to the system increases competition, which hopefully over time will drive down prices for everyone, including the government.
Yeah, I'd add that I think there's a value in itself to like flatness and kind of fairness, you know? So even if what I guess I'm saying is I'd be willing to tolerate even a little bit of a spending increase or something like that if it's less distortive, right? I mean, what we're trying to do really here with that question, and it's a great question, is kind of like compare apples and oranges, right? There's like a money cost on one side versus a different kind of value on the other side about like I said, I put it in terms of like fairness or non-discrimination between like types of providers and situations like that. But you would have to tell me that. I mean, maybe if the magnitude of the cost increase was like so enormous that it was like like really putting other things in tough positions and at risk and like busting budgets left and right and everything that there there is a world in which that could, I guess, overshadow the value of like flatness and fairness and treatment of laws, but unless I don't know, absent that kind of scenario, I would opt for the flatness and fairness. I mean, think about this in terms of like I don't know, like tax policy in general or something like you can kind of test out this idea with thinking about like what if there was some benefit given to everybody, but one group of people was arbitrarily cut out of it, right? Like there's a stimulus check that goes out to everybody in the United States except for redheads or something like that. It would be like a weird cutout. And yeah, okay, by excluding redheads, lessened the spending on that program, which is maybe a bad idea in the first place. But like there's like an unfairness there too, which is almost, I don't know, like insult to injury on top of it all. That's an additional thing that I think is important because those kinds of things then distort behaviors down the road, and then there's other unintended consequences. And I think Colleen laid some of those out.
Jared, your point that, if it ended up being so expensive, like so if we did this, if we allowed physician-owned hospitals, and then that just became such an increase in spending or like offset the market in such a way that it just became so destructive. That's the argument that the American Hospital Association is putting out for its opposition to physician-owned hospitals. I mean, they're literally saying if we allow physicians to own hospitals, those doctors will create this system where they'll steal all the lucrative patients for all the lucrative procedures, and they'll leave the existing corporate and nonprofit hospitals, the dregs, like only the Medicare and Medicaid patients with no private payers at all, and they'll have to like clean up the mess, which is actually a little bit ironic because if that were possible to do, then we would still see physician-owned hospitals growing
Hmm.
because they don't have access to the Medicare and Medicaid dollars. So if it were possible to do well enough with the private money alone, they'd be doing great. We wouldn't see this decline in physician-owned hospitals.
Yeah, so you're saying that their painting of that scenario is like a fear mongering kind of like they don't have
Yeah,
they don't have data to back that up that that really would happen or
I mean,
um
they're projecting data, they're making up data saying this is probably
yeah
what would happen. But the American Hospital Association is putting out articles saying, like, we should not, like, we're fighting the fight against physician owned hospitals because if physician owned hospitals are allowed to accept Medicare and Medicaid dollars, then they'll expand and grow and they'll steal the lucrative patients and leave all the less um, profitable care for the traditional corporate non-profit hospitals to like kind of clean up in the
Mhm.
background, and those hospitals won't be able to, they'll fail because they won't be able to make any profit because all that will have been stolen by the physician-owned hospitals.
Yeah, which is sort of on them to prove and like make a I mean they can't completely speculate on that if they expect it to carry water, right? I mean they're gonna have to have real numbers on it and they'd have to really make a a
Yeah, I mean,
plausible
they're
case,
putting
right?
out numbers.
Right.
They're saying like we stand to lose a big chunk of money if physician-owned hospitals are allowed to operate in a neutral way.
Yeah, but I think the wider context here, especially to this argument that, well, letting physician-owned hospitals is a threat to taxpayers, as perhaps the American Hospital Association is arguing, is that the whole system is a threat to the taxpayer, right? In a certain respect, but because it's also tied up with things like your ability to practice medicine, your ability to get care, like the answer to that isn't just to slash spending blindly, right? Because like, well, you actually need to kind of like unwind the whole thing, right? And it's
Yeah.
so like just looking at the public expenditure and thinking like, well, like whatever reduces it is good. It's like, well, no, that it's like all of our interests uh, and freedom in many ways is tied up into this system, and without creating private alternatives long term, if you get rid of those, well, yeah, then you massively affect people's ability to practice and receive care, which is not right. Not
Right.
because like, well, they have some right to it, but it's because their rights are tied up with all this funding. And I definitely think that the narrative from the American Hospital Association is starting to shift. My concern now, though, is that it's just going to shift to the other side. People are going to crack down on corporate-owned hospitals. We already see this on the state level with the corporate practice of medicine, and people are just gonna be like, oh, well, then like we're just gonna like support like physician-led healthcare, and like that's the real alternative to corporate-owned and led healthcare. But for me, that's a massive tragedy, and like that's gonna have its own problems, right? Because both corporations and physicians have unique values to provide the healthcare system. Corporations have capital, they have business expertise. Physicians have medical expertise and like in the relationship with patients. Why are they fighting, right? Like and like why wouldn't we be better off if we actually make it easier for them to work with each other? Because if you actually look at the laws, both federal and state, they kind of just like separate doctors and corporations in a way that's kind of unnatural from like a free market perspective. Like in an actual free market, you wouldn't see this like radical bifurcation of like, well, these are physician-owned hospitals and this is a corporate-owned hospital. It's a, well, you probably wouldn't have that because like you can't like afford not to get the investment and expertise from businessmen, and you can't afford not to get the input from physicians. And so for me, what I hope will actually happen is a realization that like, well, let's not just switch from corporate owned and led healthcare to physician owned and led healthcare. Let's figure out a way to let these guys work better together.
Yeah. Yeah. And for all these different models to compete as well, that's part of it. Yeah, the value that that different models can bring in different settings is important. There's the whole thing about rural care versus urban care, and where are you going to have as many hospitals in rural settings? Obviously not. And so that's where physicians work well and can thrive. And then, but of course, you need them to be able to work with hospitals that are not too far away. It's yeah, the ecosystem, kind of divvying up the ecosystem as has been done, and as emerges when these policies that pit these groups to get against each other unnaturally and everything. Um, it's not very productive. I don't think. I think in a healthier market, we'd see these different groups working together in new and innovative ways that we might not even, there might not even be examples of these things in existence right now, because of the way the ecosystem is set up and reimbursement laws and rules and everything. But we could see some real innovation if we weren't to limit it this way.
Yeah, I mean, I think the corporate practice of medicine laws from states seem like a backlash to the ACA's 6001. And so this to me feels a lot like some of the um, anti-vertical integration, kind of anti-corporate laws in healthcare that are coming out now, kind of as a backlash against private equity and against the kind of conglomerating of insurance and PBMs and things like that. And like we're seeing that as these groups get bigger and bigger and have more and more power and no competition, they're able to begin doing things that are officially legal, but feel very much like taking advantage of patients and taking advantage of insurance dollars or government funding or whatever it is in a way that feels slimy and that makes our care more complex and more difficult, makes the system more difficult to navigate rather than easier to navigate. And so what's happening is um, the government is coming in and saying, well, let's break this up, let's break that up. But then we lose the benefits of some of those things. Like I can get all of my everything done under one roof. Um, and all of my doctors know what's going on with me. Uh, and so, I think similarly now we're looking at this kind of corporate practice of medicine versus physician-owned hospital, with physician-owned hospitals, or are we anti-physician-owned hospital? And it's kind of like a layering of regulation upon regulation rather than kind of looking at the underlying problem and saying, can we just go back to a situation where there's more competition and more neutrality and more choice for patients?
And I think this points to the need to have like an actual principled perspective on what free market reform looks like. Because I think very often the tendency from people in our wider world is to see whoever is dominating the healthcare system to accuse them of regulatory capture, of rigging the system, which is not to say that those things don't happen. And then to think like, okay, well, what freedom looks like is that we go after them, right? Whereas from my perspective, really the real divide isn't between like corporations or doctors. For me, the real divide is who actually wants to change the system in which we're all freer to interact with one another in a way that's beneficial, and which of course long term, yeah, like public expenditure will go down, but if like that's your short-term metric, you're never gonna actually get there, right? Because then you're just all stuck. So there's those people on one side and those on the other who necessarily see the freedom from one party as a threat to the other.
Right. Yeah, and I think what goes hand in hand with that too is that if so, if you force a choice, you ask somebody, you explain somebody this issue of this particular exclusion, and then you say, okay, are you for it or against it? I mean, Yeah, you kind of throw your hands up. It just in isolation, it's hard to, we just spent I don't know 20 minutes talking about how there's stuff to be said on both sides. But really, the bigger picture is to say, well, you can come to a position on it if you're allowed to say and advocate for several other changes too, right? Like I think you can reasonably argue for the repeal of 6001 and this exclusion if you're also allowed to get into that debate and that conversation. The fact that what you also would insist on would be some other changes to the corporate practice of medicine laws. The site neutrality thing plays a role in this. All roads ever always seem to lead back to con laws, certain certificate
Yeah.
of need, because and that's part of the overall ecosystem of competition, and because these are all the checks and balances that keep a market working well. But there's so many blocks and problems with preventing markets from working well that these checks and balances aren't happening the way they might otherwise. And so again, in isolation, if you say, well, what do you think what do you think about physician-owned hospitals? If you only get to express one opinion on just that isolated thing, I'm not even sure what the right thing is. But you can argue for a menu of things, and at that point, I think you can come down on one side or the other of this.
I think that's largely true, but Jared, but I also think that even if you only repealed Section 6001, I think that would still be a benefit to freedom in the healthcare market and to moving things kind of in a positive direction. I think the benefit would be smaller, and you probably would see an increase in certain markets, depending on the state, you might see some increase in like payments from Medicare and Medicaid for a little while until things kind of evened out. But I think there would be a lot of states where it wouldn't make a difference anyway, because con laws that are in place would make it so that any physician group that tried to start a practice would just get voted out by the incumbents. So it would so there in some places it would do nothing, and in other places it would sort of nudge things toward freedom. In an ideal world, we would hit a lot of these issues and kind of reform many of them at once. But even if you just did one thing, just repealed Section 6001, I think it would still be a little bit better, at least in some states.
I think I agree with both of you. I mean, like in some sense, we need both. I think we need to repeal Section 6001, and we can't stop there. We need to do much, much more. And I think we'll leave it at that for now. I would like to thank our audience, and till next time.
All right, thank you.
To stay up to date, subscribe to our show from whatever podcast platform you're listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.